Hello, good morning, and welcome to my presentation. My name is Jacinta Ebigide, and my student ID is 19202653. Today, I will be reflecting on a multidisciplinary team simulation, which I found to be a great learning experience. This simulation allowed me to gain personal insight into how professionals work together, make decisions, and resolve conflicts using a case study. As the ward manager, I navigated the complexity of leadership, advocating for the patient, and bringing the team together while keeping our conversations constructive even when we face major differences of opinion. Case study. Ellen is a 65 years old patient with a history of bipolar disorder, schizophrenia, and schizoaffective disorder. She is known to act impulsively and experiences auditory hallucinations and grandson delusions. Since Ellie has a history of absconding, significant concerns exist regarding her safety. The last time she absconded, she went to Norfolk under the false impression that she was married to the Duke of Norfolk. Ellen's family and the community team advocated for a structured home trial because they believed Ellie could be safely supported with the appropriate intervention. Due to her mental health condition, the inpatient mental health staff feel she should remain in the hospital. Navigating my role. The ward manager role was assigned through a balloting process, which introduced advantages and disadvantages. Balloting ensures that selection processes was unbiased and democratic, giving every team member an equal opportunity to take on leadership responsibility. This approach promoted fairness and prevented subjective bias from influencing role allocation. Additionally, it allowed participants to develop skills they might not have otherwise pursued voluntarily, encouraging personal growth and professional growth according to evidence. However, balloting in an MDT setting also presented notable challenges. The ward manager role requires specific leadership skills, crisis management abilities, and familiarity with complex decision-making processes. A randomly assigned leader might not always possess the necessary expertise or confidence to effectively manage the team, potentially leading to inefficiencies or conflicts, according to evidence. Furthermore, since some individuals might be less inclined towards leadership positions, balloting could result in reluctance and discomfort, impacting team cohesion and overall performance. This experience highlighted the need to balance fairness with ensuring that leadership roles are assigned to individuals capable of assuming responsibility. My role as a ward manager. I was happy with the ward manager role because it is vital in connecting inpatient care with the transition to community support. Inpatient psychiatric wards serve as a vital spaces for mental health recovery, offering not only a secured environment but also personalized support that facilitates a gradual reintegration into community life, according to evidence. The ward manager ensures that patients receive consistent care and stay safe throughout their recovery. It requires critical thinking about our systemic gaps and the consequences of discharge decisions. As the ward manager, I needed to balance leading the team and advocating for the patient, ensuring that all clinical, social, and legal aspects came together in a clear decision plan. I did not find this easy, as our perspectives sometimes conflicted, making me uncomfortable. Ward managers played a crucial role in promoting high performance healthcare team. However, they often face challenges due to role ambiguity and the pressure of hierarchy, according to evidence. Early situation brought to light the challenges of helping people who face serious mental health issues. Our impulsive nature and mental state show that assessing risk was not just a one-off task, but require continuous attention and thoughtful decision making. In mental health care, risk assessment and safety planning are not just a task to be completed. They are ongoing processes that demand continuous evaluation and reflection rather than being viewed as the one-time assessment, according to evidence. Although my crisis planning and experience were necessary, I needed to closely examine whether our current system addressed her needs or kept her in a loop of hospital visits. While collaborating with a diverse team, I frequently wondered if our best practices were genuinely effective or if certain limitations prevented us from offering real and lasting support. Discharge planning for individuals facing severe mental health challenges is complex, frequently falling short in delivering enduring support, according to evidence. On conflict resolution, during the meeting, we encountered significant challenge in managing the different views among team members, especially when their professional priorities regarding early care did not align. The medical team expressed genuine worries about the risks of sending Ellen home too early, especially considering her past struggles with sticking to her treatment plan. The social worker and the family advocate highlighted her independence and the positive aspect of being part of the community, suggesting that staying in the hospital for too long might take away our ability to be self-sufficient. Conflict often arises within multidisciplinary teams, especially during discharge planning, as professionals exploit their varying priority, according to Lam et al. 2013. This disagreement caused some tension and heated things for a while, showing just how complicated it can take to make a decision across different fields. It became clear that professional roles and institutional structures can sometimes hinder collaborative care instead of supporting it. The deadlock showed the stormy stage of team development outlined by Tuckman, 1965, where different opinions tested group unity. Yet it highlighted a real struggle, finding the right balance between keeping patients safe and respecting their personal choices, a challenge we often face in mental health care. Communication barriers and differing professional expectations significantly contribute to discord within multidisciplinary team, highlighting the crucial need for structured coordination among team members, according to evidence. The situation requires more than handling conflicts. It asks for a thoughtful look at whether our systems truly support care that puts patients first or if they just stick to strict, cautious methods that might not always benefit the patient. This experience made me think about whether the current decision-making processes really promote genuine teamwork across different fields or just highlight the conflicting priorities in healthcare. Structured multidisciplinary meetings build association and enhance discharge effectiveness, enabling teams to tackle risk management while promoting patient autonomy, according to Whitney et al. 2024. Decision making. At first, I rely on my past experience to make decisions, thinking that since structured discharge plans had worked well in other situations, Ellie's move back home would go smoothly too. Relying too much on past experiences can make a complicated situation seem simpler than it really is. Standing 2008 cognitive continuum theory highlights that clinical judgment falls on a spectrum between intuitive and analytical reasoning. Looking back, I realized that my initial approach was more intuitive than based on thorough data-driven evaluation. The psychiatrist and the consultant rightly questioned this assumption, emphasizing the importance of a more structured evidence-based risk assessment, considering Ellie's history of not following recommendation and acting impulsively. Their intervention made me examine whether I had been leaning too much on pattern recognition instead of assessing the risk factors more comprehensively. This highlights a common challenge in clinical practice: how being too familiar with previous cases can lead to bias in thinking, resulting in overconfidence about what to expect according to evidence. This experience made me reflect on balancing our feelings with careful analysis when making clinical decisions. While professional judgment is essential, leaning too much on past situations without adjusting to the unique details of a case can result in significant oversight. As I look ahead, I see how crucial it is to question my own beliefs and adopt a more explicit and more thoughtful way of making decisions, especially in high-risk situations where the safety of patients is involved, according to evidence. A key part of my job was making sure we took responsibility for our decisions. At first, the absence of strong leadership in the MDT resulted in scattered conversations and confusions about everyone's role. Noticing this gap, I took on a supportive leadership style, making sure that everyone understood their roles and that our decisions followed important legal and ethical guidelines like the Mental Capacity Act 2005 and the Care Act 2014. As part of this process, I took the responsibility for structuring the final discharge plan, ensuring that it incorporated clear post-discharge monitoring strategies. This included establishing regular community psychiatric nurse visits, formulating a crisis escalation framework, and securing family involvement in early care. While these measures provided a structured safety net, my reflection on the process revealed a key leadership gap. I hesitated in asserting authority earlier in the discussion, which may have prolonged decision making and contributed to the initial tension within the team. According to evidence which emphasized the importance of proactive role delegation in effective teamwork, yet my approach was more reactive than strategic. Rather than guiding the discussion from the onset, I found myself stepping into a leadership role only when the decision-making process required final structuring. This experience made me question whether my reluctance stemmed from an overly facilitative approach, seeking consensus at the expense of decisive leadership. Accountability. Accountability was crucial in ensuring that our decisions were clinically sound, ethically and legally compliant. According to evidence, Accountability theory provides a framework for understanding how responsibility is distributed within the healthcare settings. Evidence suggests that accountability is structured around three core elements: professional, legal, and ethical obligations. In the context of the MDT, I ensured that accountability was embedded in every stage of the decision-making process. Professional accountability requires us to make evidence-based decisions aligned with best practices. Legal accountability meant that our discharge plan adhered to relevant laws, including the Mental Capacity Act 2005 and the Care Act 2014. Ethical accountability involves making choices and prioritizing patients' autonomy while ensuring safety. Applying the GRIFT framework, which helped me structure the discharge plan with clear rules, documentation, and follow-up mechanisms to ensure long-term success. Furthermore, personal accountability influenced my leadership style. Initially, I hesitated to ascertain authority, fearing that a directive approach might create resistance within the team. However, I learned that taking ownership of decision-making process was essential in guiding the team towards a structured, patient-centered solution. This experience reinforced that accountability is about assuming responsibility for outcomes and demonstrating leadership in moments of uncertainty. Moving forward, I see the importance of blending teamwork with confidence and ensuring that leadership is present at the end and woven into every step of interaction. Improving my ability to step up earlier in conversation will help our team work better together and create a more explicit and more confident approach to planning care that focuses on patients. Thank you.